Okay, welcome everyone. I'm Sharice Magoon and I work in the Department of Lifelong Learning at UT Health San Antonio School of Nursing. I will be moderating the session today. You were sent an email this morning from Cynthia Gutierrez. At the bottom of the email, it explained how to complete the evaluation and to get your CE certificate. If you have any questions, please get with her after the presentation via email and she will type her email in the comments so that way you can contact her. This symposium is sponsored by Texas Health and Human Services Commission in partnership with UT Health San Antonio School of Nursing. Texas recognizes June as Neonatal Abstinence Syndrome Awareness Month. You can learn more by reading House Bill number 405. During the presentation, we ask that you please keep your camera and microphone off. If you have a question and you want to type it in the chat, I'll be reviewing those and I'll be telling those to the presenter, or we'll read them at the end. We'll kind of play it by ear, but go ahead and type those in the chat. And then at the end, if you have any questions, you can unmute yourself or type it in the chat and we'll address those. Let me introduce the presenter today. The presenter is Ed Tronick. Dr. Ed Tronick is a developmental and clinical psychologist. He is professor of psychiatry and pediatrics at the University of Massachusetts Chan Medical School. He's the director of Child Development Unit. He is a past member of the Boston Psychoanalytic Society and Institute and the Boston Process of Change Group, a founder and faculty member of the Touchpoints program. He created Infant Parent Mental Health Postgraduate Certificate Program at the medical school. He developed the Newborn Behavioral Assessment Scale and the Touchpoints project with TB Brazelton. With Barry Lester, he developed the NICU Network Neurobehavioral Assessment Scale. He is currently working on developing norms for the neurobehavior of clinically health newborns and collaborating with Rosario Monterizo, hopefully I'm saying these names correct, in Milan on a multi-NICU examination of developmental caretaking and its effects on preterm infants. Dr. Tronick developed the still face paradigm and recently the caretaker acute stress paradigm. He continues to do research on the effects of maternal depression, other affective disorders, and drug exposure on infant and child social emotional development. Current research focus is on infant memory for stress and epigenetic process affecting behavior. The research utilizes the still face and other stress paradigms and multiple measures, including EPR and EEG, salivary carousel, and skin conductance, as well as behavior. For the state's initiative to screen women for postpartum depression, he is working on epidemiologic data sets to understand the nature of the responses to questions related to depression and help seeking of women in different ethnic and racial groups. Relatedly, studies are being carried out on the long-term relation of stress hormones to SES, exposure to violence and other community factors, and possible unique effects related to health disparities in ethnic and racial groups. He's developing conceptual models based on dynamic system theory for dyadic infant mother adult interactions, including the mutual regulation model and the caretaker buffer transducer model. He has published more than 300 scientific articles and 7 books. Several hundred photographs have appeared on national radio and television programs. His research is funded by NICHD and NSF. Without further ado, I'll hand it over to you, Dr. Tronick.
Thank you. It's a really generous introduction, and I'm very pleased to be here and to know that Texas has an NAS Awareness Month. It was something I was completely unaware of, and it's certainly something that seems to be effective in bringing information to the community of clinicians as well as researchers and parents. And I've already talked with a couple of my colleagues at the medical school about the possibility of doing something similar, or Charisse, perhaps just stealing everything that you've put together and trying to get it out in our state and to our clinicians. So I'm really, really pleased to be part of this. Today, I want to talk about the buffering and transducing effects of parenting, infant development, infant neurobehavior, interactions and maternal stress. The outline of the talk, if I hold to it, is I want to describe something very basic about energetic resources that are needed for infants and how critical informational resources are for infants to grow their bodies and their brains. So the focus there will really be on normal, typical development. And I want to describe the neurobehavioral abilities of newborns have for acquiring the needed resources of energy and information from the world around them, especially from other people. And then I want to review some of the research on neurobehavior and dyadic interaction of infants and children exposed prenatally. I want you to know that while I've worked extensively in the past with infants exposed to in utero cocaine, and I've done some studies on the effects of methadone and even opioids on infant behavior, I don't consider myself a really deep expert on these topics, but I try to see them through the lens of a developmental perspective. One of the things I want to do, because I see myself also as an experimentalist, is to discuss the methodologic limitations of these studies and why they're so important. Hopefully we'll get to it, and I'll give you a little presentation on a new maternal stress paradigm that I've developed and its effects on dysregulating infants. And then I want to suggest, without any sarcasm, that we should be working with dyads, mothers and infants, with exposed dyads. And one way to be with them is to be like an infant. And we'll talk about that. And then I want to present the buffer transducer model. So you can see there's a lot to get through. So Claude Bernard, probably one of the founders of physiology in the 1800s, said the primary task of the organism is to maintain the constancy of the milieu internal. Successful regulation is the condition of a free and independent existence. So this was the introduction of the idea of homeostasis. But one of the things that Claude Bernard really made a mistake on, and I do this really humbly, is that he failed to realize that, at least in humans, that the system for regulating homeostasis is a dyadic system, and that infants and children and caretakers are components of a dyadic system. And that's the way the milieu internal is regulated. And it's done with scaffolding and regulation by caretakers. And it helps infants and young children to actively gain and acquire the resources that they need for development. And it leads to growth and development of systems, and it allows them to acquire more energy of growth and regulation. So while first I want to be talking about energy, calories, nutrients, I want you to see that even that fundamental process is a process that has to do with dyadic regulation. I'm having a little trouble advancing. So the mutual regulation model says that the regulation and provision of energetic resources and of culturally appropriate information leads to typical development. You have the mother, the infant, a dyadic interaction between them. And when they're successful in gaining resources, it results in typical development. So let's first talk about energetic or nutrient resources. One of the facts I hope you walk away from this talk with is that the idea of distress is 5 or 6 times more energetically demanding than is a calm and quiet state. And that distress wastes resources, energy that could be better utilized for growth and development. And it precludes the acquisition of information. Distressed infant can't explore the world, can't do anything but regulate the distress. And a distressed infant is crying, is dysregulated, is utilizing energy that is wasting energy on controlling that distress instead of being able to use that energy to grow and develop. And while this may seem obvious, it was probably my grandmother who told me, well, you have to feed them and keep them hungry. It's often not recognized as really critical in terms of how we think about development. But if you can think about energetics, nutrients being a regulatory process, a dyadic process, it then becomes even easier to understand how behavior and emotions can be seen as a dyadic process. One of the things that's critical is that the caretaker scaffolding calms the infant and reduces the energetics cost. It's one of the primary functions of caretaking. And here we probably have the world's best caretaker, at least he was the world's best caretaker, Barry Brazelton, calming an infant.
Sarah, what you fussing about? Sarah, Sarah, what you fussing about? Sarah, 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 get your hand in your mouth. That's a girl. That's a girl. That is so nice, Sarah. That's fine. Keep it there, though. You can do it.
So what you can see is that it's a process of mutual regulation. But the other thing to see is that the infant needs informational resources to grow and develop their mind and their brain. And the infant faces a problem, which is what meaning can I make of myself in this VUCA world of people and things? Remember, the infant doesn't come in knowing what culture they're born into, what kind of environment that they're born to, but they have really powerful mechanisms for learning about the world. And the world is a VUCA kind of place. And what do we mean by that? It's a volatile, uncertain, complex, and ambiguous world. And that's what the infant has to take hold of. And the phenomenon is, especially after this pandemic year, that many of us face the same kinds of problems, especially the issues about uncertainty, complexity, and the volatility of the world. For the infant, much of what they have to learn is arbitrary. Cultural practices are often arbitrary. They're uncertain, they're ambiguous, And they're culturated in complex ways, ways that are different from one cultural complex to another. So how is a baby supposed to make a meaning out of this mess or this mess? Or, for example, what about an American child who makes of her, what sense can she make of herself and her culture-rated way of experiencing the world? Why does it mean for me that I'm alone so much of the time and always with things and not people? What meaning can I make of myself in that world? And realize that whatever the meaning making, it is all too exhausting. Just too many different ways to figure out what meaning is to be made. But perhaps they're all just good enough. It's exactly what Donald Winnicott said. And now that we have so much more diversity of our populations and so much more variation in parenting, it's not that there's an optimal or perfect form of parenting. There's a variation, a variety of parenting. And I think the phenomenon is that most parents in healthy, stable situations parent in a just good enough way. It doesn't mean it's perfect. Indeed, it means it has plenty of errors, but it's good enough to foster development. Now, newborns and young infants are not helpless, but they are limited. That is, they have resources for gaining information about the world, for gaining resources in the world, for gaining information and energy about the world. But those resources are limited. You saw that with Dr. Brazelton. The baby is crying. He can bring the baby down with his voice. His signals help the baby to self-organize. And at the same time, we know that in a bit of while, or however it takes, the infant will run out of those resources and require regulatory support from someone else. So what I'm going to show you are a few observations about infant neurobehavioral capacities, the kinds of capacities that are affected by opioid and other kinds of drug exposures. And they're demonstrated from observations from the neonatal neurobehavioral scale I developed with Barry Lester to evaluate the full range of newborn behavior. The scale looks at 13 different primary aspects of infant behavior. I won't go through all of them, but the critical ones, I think, for this talk are habituation, the infant's ability to disregard insignificant information. After all, the infant's in an environment where there's plenty of noise, other things going on, other people around. Some of that is important, and a lot of it is of not any kind of significance to the infant. At the same time, the infant has the capacity for attention to focus on significant things, like other people in the world. Another capacity is that the infant has the capacity for regulation. It's their ability to self-modulate, to self-control their own physiologic and behavioral responses. So they can get upset, they can calm themselves, they can work to take care of themselves. Then there are a number of other things. One piece of the neurobehavioral scale that I like is handling. We look at how well the infant can adjust to the handling by another person. And another one is excitability. How excited does the infant get? How distressed do they get? How intense is that distress? And at the same time, when they're in an attentional state, how focused are they? How well organized are they in doing that? And the last is their response to stress. That is, what kind of effects, what kinds of capacities do they have when they are stressed, say by too loud a noise or being handled too roughly? Are they able, do they just go into an agitated, excitable state? Are they overwhelmed? Or are they able to cope with the stress and cope with that state of arousal? So here's an infant doing habituation. And in this, a light is flashed this is a newborn, light is flashed in the newborn's eyes. Typically the infant reacts and then over time begins to shut out the stimulus and to control their reaction to it. So this infant does not react very strongly, but does react to the light. The second light stimulus, the baby moves again. Perhaps a little less. No, there's some more movement. Seems a little delayed. Third stimulus, the infant doesn't react. So the infant is habituated to this stimulus, and it's a sign of being able to shut out non-significant events. Another capacity the infant has is for visual and auditory attention. Infant can follow the red ball. And notice the hand movements and notice how smooth the hand movements are with this baby. And look how far the infant can track with both head and eyes. Loses the stimulus, but he keeps holding himself together so he's able to self-regulate himself. He can track a little bit vertically. Loses it. And notice how he's keeping himself organized while this is going on. And now another stimulus. Stills. Doesn't turn to it yet, but there he starts to look around for it. And so he doesn't fully orient, but he's quietly listening to it. See how he stills?
Yeah.
There he goes. Visually, he seems a little more alert and attentive. And here's handling. Now the ends, you've seen some of the items in it, has many more items that then can be organized into different kinds of profiles. So this is a study of normal, typically developing infants, healthy infants. And on the bottom, you see capacity for orientation, handling, self-regulation, arousal, all the way to stress and abstinence scores. And then you see there are 5 patterns. 2 of these patterns, this pattern and this pattern, we consider dysregulated, that the infant has poorer scores on orientation, self-regulation, high levels of arousal, high levels of excitability, hypertonicity, really reactive to stress and abstinence. Whereas the first and second class have much more moderated reactions, better orientation, better response to handling, and self-regulation. So we get a contrast in profiles of the neurobehavioral capacities of the infant. And when we look at medical outcomes, what we see is that the infants with the most dysregulated neurobehavioral patterns are the ones most likely to have medical problems later on in development. So some of these are like abnormal ultrasound readings, chronic neurologic abnormalities, disease with risk to the brain, and CP diagnosis. So that comes from the infants who are really dysregulated. And then we look at the developmental outcomes of the profiles of these infants. We use the Bailey scales of development. We use the CBCL, and then at 4 and 5 years of age, we're using full IQ evaluations. So look at the dysregulated pattern, this profile for this infant. And these scores are highly abnormal, including at 4 to 5 years of age, the infant having a much lower IQ, leading to poor outcomes. And the same is true for the lesser dysregulated pattern. And then there are the infants who had normal or typical patterns who are just doing much better developmentally. So during the newborn period, by making neurobehavioral assessments of the infant, we're able to make some predictions about their later outcome, both their medical status and their developmental status. And importantly, in terms of the idea that I will talk about a bit more about gaining information from the world, that the infants who have problematic neurobehavioral patterns are infants who are going to have less capacity or more compromised capacity for gaining information. They're going to be harder to handle. They're going to be more easily overwhelmed by stimulation. Their attention to tasks is not going to be as good. So they're going to be compromised in their capacities to gain information so that they bring that to the world as they try to gain information. So here's an example looking at infants who were randomized to morphine or methadone treatment for neonatal abstinence syndrome. So here we found that there were 3 profiles. Profile number 1, we saw as dysregulated, and then there were profiles 2 and 3, which were less dysregulated, but I have to say that they were more dysregulated than the infants I just showed you. So most of these infants have some level of dysregulation, although the infants with, I'm trying to find the blue, with the blue profile are the ones that are doing better than the others. But here you see dysregulated leads to high energetic costs, right? Because they're going to be distressed more of the time, and they have poor acquisition of neurobehavior. So profile 3 is an atypical profile. We found 24 infants that had that profile. 12 of them were in the morphine group and 12 of them were in the methadone group. They required substantial handling. Maybe it took a lot to calm them down when they were distressed. They had poor regulation, they had higher arousal, and they had higher excitability. They were hypotonic, they were stiffer, and they had poor quality of movement, and they showed more signs of stress. There was no difference between the morphine group and the methadone groups. And the infants with the atypical profiles had more externalizing behavior, more internalizing behavior, and total behavioral problems with the CBCL, the Child Behavior Checklist, when they were 3 years of age than those with the typical profile. So you can see that the exposure to the drugs and then the treatment with morphine or methadone didn't either overcome their dysregulation or in fact may have added to some of the qualities of their dysregulation. Now, all infants use these abilities to gain information about the world. And all infants make meaning out of their moment by moment, chronic, constant, and reiterated experiences. Singular experiences may have an effect on the infant, but what really helps them to organize are the experiences that they have in repeated many, many times. So one way you can think about how infants learn about the world is learning about the game of peekaboo. Now, that doesn't seem like a lot of other things that the infant is doing. It's learning a game that's arbitrary, that we created. But peekaboo isn't something that when you, and those of you who've played with a 6-month-old playing peekaboo, you know that the infant is not playing peekaboo with you. You play both the peekaboo person and you're the booer. You do the whole thing. And the infant watches, pays attention, maybe reacts to it in some way. But over time, what happens and with repetition, the infant gains a little bit of the game, knows a little bit more. And into the second year of life, by around 14 or 15 months of age, the infant can play the game and can initiate the game. And the infant can play both the peeker and the booer side of the game. So they have the game fully under their control. They learn both their role, which is to be the reactor to it, but at the same time, they also learn the role that the adults play. And I made some estimates, and these are just pretty much made up, but you can estimate that the game was played at least 2 times per day and is played for 18 months, for 14 times a week, for more than 1,008 times until an infant can fully play the game. And if you have grandparents around, the infant is playing that game many, many more times. So let me show you a little game of peekaboo. And watch how this baby knows some pieces of it, but not other pieces of it.
Ah, boo. Ah, peekaboo. Ah, boo, 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 boo.
So he has some anticipation.
Ah, boo, 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 boo. Boo.
And he signals.
Oh, you. Boo.
Did you see that quick look away? It's taking a break on his part. And now it's going to go into slow motion. And I want you to see how his affect has changed because it's a little too exciting for him. She comes back and now he turns away.
Daddy, where's Mommy?
And for him, the game is pretty much over.
Where's Mommy? Peekaboo. Where's Mom? Ah, boo, boo, boo.
And while that's a game, clearly, just think about the other activities that you could think of as games that the infant is learning nursing and feeding, how many times a month, changing, dressing, face-to-face play, toy play, social games, being cuddled, the infant learning. How is it that we cuddle each other? And what about the baby waking up and being soothed? What kind of routine is put into place there? All of these routines are repeated many times, and at the same time, developmentally, they change. The waking up and being soothed starts out one way, gets repeated a bunch of times, and then changes. And then it'll change again. But it gives the infant many reiterations of it to know what's going on. And what about being crying and being soothed? The infant cries, parents soothe in one way, they find a way that really works. After a while, that doesn't work, and then they have to figure out another way. And each time the infant is learning new ways to, new games with the parent. This is the way that we are together. And that's especially important when you get into things like play, where you want the infant to be developing. You want the infant to be gaining more information about the world. So here's an example of an infant and a mother playing together. And this is skin response. And you can watch the excitement of the infant and the excitement of the mother. Mother's on a different scale than the infant. But here's an infant learning, and you'll see a particular game, a particular way of being with her mother.
Niet aan je sok trekken. Niet aan je sok trekken. Ja, ja, ja.
Now, here comes the game that they've created together, and this is a pretty unique game.
Bak, zit je maar bij de neus te happen. Hier. 1, 2, 1, 2.
While this is a game, this is a way that they're together, sharing affect, playing with each other, figuring out what to do with each other. But at some point, this game is going to be fully taken in by the infant, and a new game will be learned. So this interaction looks something like that, that there are mismatches and matching states. Say both of them smiling together, but the infant may be looking off to the side, or what that mother did when she looked off to the side. But there's a reparation from the mismatching state to a matching state. Then there's a new mismatching state, a new reparation. And this interaction goes from one pattern of matching to mismatching, back and forth. And what we found in our studies, that matching states, attunements, only occur on average about 30% of the time. It really varies across dyads. Some are much better at it than others, but the average is about 30%. But what also happens is that the repairs come frequently, and they bring the interaction back to a matching state. So interactions like this lead to regulation of energy and growth for positive experience. And as my colleague Arnold Modell has said, the vitality of the self depends on the capacity to generate meaning, gaining information from the world. The ability to gain meaning, this little baby saying, I know who I am because I'm playing with you and we do this together, is a psychic triumph leading to mental growth, expansion of consciousness, deep pleasure, self-regulation, and connection or attachment to the other person. Now, what happens when there's a break in this? And this is the still face in which will see the still face and the infant's reaction to the breaking of connection between herself and her mother. And later on, I'll show you their reunion when they get back together again. You can see how this lack of response on the part of the mother is dysregulating the infant. And one of the things I wanted to point out here is that when you saw the baby cough at the mother, this is a 6-month-old infant. This is a fake cough. The infant has come to know in other circumstances that when she coughs, her mother responds. And so the cough is an attempt to get the mother's response. But you can also see that without the response, without the mother interacting with the infant, that the infant gets dysregulated and is having difficulty acquiring information and difficulty making sense out of the interaction. So what's happening here is that when there's unsuccessful mutual regulation of discord, when there are few reparations and few matching states, which we've done experimentally, but it's also what we see in interactions. You'll see where the interaction is not going well, that you get mismatches, and you don't get the repair back to the matching state, and you get wasted energy. The infant's wasting energy on the negative experience, and the wasted energy could have been put towards growth and development, but it leads to a compromised way of being in the world. And here you can see what happens during the still phase. If you look at heart rate, in the first still phase, the infant's heart rate increases, energy use is going up. Then they recover, but notice that they don't recover back to their baseline play. And then if there's a second brief still phase for less than a minute, heart rate goes up even further. And when it comes down, it does not come down to what happened before, and it's not where the baseline was. So all of this is representing an increased energetic cost and a period of time during which the infant is less able to gain information about the world. Now, imagine what would happen if the game included hitting, how many times, neglect, or if the child was witnessing violence or screaming. I'm not calling these actions games, but what I want you to think about is just like peekaboo, the infant who regularly witnesses violence is going to learn about violence and how to react to violence. The infant who's repeatedly screamed at. What about the failure to repair? What if in the interaction, there's just periods of time, many little periods of time where mismatches are not repaired and the mismatch continues and the infant is stressed with these. So just like the infant learns how to cuddle and to have social games when they're going well, the infant learns patterns of behavior during these kinds of activities as well. So here's an example of a possibility of the infant learning a game of threat. And I'll let you watch this video and then you can see, if you can see what the infant is responding to.
Ow, 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 ow. Go, here, go, go. Let go of my hair.
Now, if you have quick eyes, what you were able to see is that the mother made an angry, bared-toothed face at the infant. And the infant here picks it up right away. He just sort of stops in midair. And then here, he puts his hands in his face as if she's about to hit him. So what will he learn? What will the meaning he make? Anger, threat, danger. And what if this happened once? What if it happens 3 times a day that there's this kind of threat? And what happens if it's followed by a snap, a slap? What kinds of games will the infant be learning? And what about this situation where there's a game of neglect, a lack of repairs? So this is the still face again, where the infant is saying, I can't cope, I'm helpless, or I'm hopeless. I can't trust you to help me take care of things. I can't change my feelings. So the infant tries to get the mother to respond, reaches out to the mother, gets disorganized, turns away. And one of the things that happens with this kind of neglect is it actually damages the brain and it damages bodily processes, perhaps because of the energetic loss and perhaps because the infant is not getting the kind of input that he needs. And what happens if it was happening most of the time? What meaning will she learn? What meaning will she make? So a failure to make meaning, the inability to make meaning, like during the still face or during neglect, is a psychic catastrophe leading to mental shrinkage, constricted consciousness, disorganization, fear, dysregulation, anxiety, disconnection, and loneliness. And though I don't in some ways want to emphasize this too much, I think over the past 2 years of the pandemic, for many of us, what we've been dealing with is very high levels of uncertainty. And what we feel is anxiety and fear. We feel disconnected from the world. And it is a kind of psychic catastrophe. And I'm not sure we've all, and certainly we've not fully recovered. But now let me show you what happens with the repair.
What a good girl. The wheels on the bus go round and round, round and round.
And that kind of interaction goes on for longer. The baby's smiling, playing. So what happens if most of the time, what will she learn? What meaning will she make? What happens if most of the time she's getting repairs, it's a positive interaction, and she comes to know, for example, that while there will be missteps, that they can be effectively changed. So she learns that she can cope, that she can be effective, that she can trust the mother, and that she can change her feelings. I think a lot of patients that we see have the feeling that they can't change their feelings, that they're completely stuck in them. And I think a lot of that comes out of their early experience of growing up. And here how things like scaffolding or the parental regulating has positive effects in terms of energetics as well as gaining information. For example, this is during the still phase. This is the normal level or the typical level of grimacing, of distress that infants show during the still phase. But if during this still phase, the mother is simply touching the infant, not doing anything more than holding the infant, the amount of distress and the grimacing is reduced. And the same happens with gaze. During the still phase, we see the infant looking away a large proportion of the time. When the mother is simply holding the infant, there's a contact and a connection. The infant gazes at her much more during the still phase. And here's a little more complicated thing where high levels of social engagement reduces the infant's negative emotionality during this still phase. So what's going on in the play episode that comes before the still phase, when they're playing together, has an effect on the infant's negative reaction or distress during the still phase. So here's maternal engagement during the still phase. Here's distress. When there's high levels of engagement on the part of the mother during play, the distress during the still phase is reduced. So now you're having a carryover effect. Well, here's another example, which really surprised me when we found it. When the mother is more playful, vocalization by the mother during the play episode, there's a lower heart rate on the part of the infant. And here's a finding, again, which really surprised me. What we're looking at is latency to repair. How quickly does the mother go from or the dyad go from matching to a mismatching state? And we're talking about seconds here. And this has to do with the amount of cortisol that the infant experiences after the still phase. And what we see during that is that when there are longer latencies to repair, there are higher levels of cortisol experienced by the infant, higher levels of stress. And I want to point out to you that this is 10 seconds. Most of the repairs that are at the low end are like 2 seconds, 4 seconds, 6 seconds, even 10 seconds is becoming a relatively long period of time. But what happens if during something like neglect, you have a repair that doesn't take place for 40 seconds or even 30 seconds? All of those lead to more stress, more physiologic stress on the part of the infant. So what do we see with opioid and methadone experienced infants? And this is a study by Romanowitz, and I'm sure I'm mispronouncing her name. But you have the child, prenatal opioid dependence, caregiver interaction, and outcomes of the child's relationship. And you see severity of addiction, mental health issues, family support, social emotional status, stress, other variables that go along with this. Well, in studies of direct observation of mothers' interaction, I found that mothers with opioid use disorder and comparison controls had infants who were more irritable, ambivalent, disinterested. They had the mothers had greater difficulty interpreting their children's cues. The mothers were less adaptive when it came to parenting behavior. They had less flexibility. They perceived their children as having many externalizing issues later on in development, and they failed to notice the internalizing, the cues around depression. But there's a consensus, a kind of lacking on what factors mediate the observed effects on parent. Is methadone, opioid use, an independent risk factor? Is maternal psychological well-being, social economic status, and maternal attention, are they the interfactors, independent factors? Is there an interaction amongst these factors? And let me show you an interaction that I think captures some of the qualities that we might expect to see in a mother who is more irritable and less able to be responsive to her infant. This is an infant who's 30 months of age.
You know what? I think you're confused. Mommy will teach you how to do it. Now, just listen. Okay, you don't want to put it on the circle? Watch, Mommy do a basket. Mommy's turn. Watch. The basket. Richard, let Mommy do it. Mommy's going to show you again. Listen.
Look how
Aren't we going to share? Okay, Richard's
they're not
turn,
sharing.
Mommy's turn. Oh,
They're
all right, Mommy's turn. now.
interfering with each
Mommy's
other.
turn. We're going to play 21.
The baby's irritable, the mother's irritable, the infant goes to hit her, she turns away. And I want you to keep in mind that while you may be looking at the mother and the qualities of what she was doing in terms of reaching and interfering with the infant, keep in mind what the infant was doing, that the infant wasn't very available to what she was saying, did not really respond to what she was saying, pushed her hands away. So in a way, this pair has worked out a game with each other that's highly contingent, but is negative and has problems between the two of them.
You know what? I think you're
And while you're already getting it, and while we don't know exactly what the effects are, I want to show you a little experiment that we did where we exposed mothers to an infant crying or an infant gurgling. And then we watched how the mother played with the infant after she was stressed by the crying. And I'll play the crying for you, which you just heard a little bit of. Mothers report that this is pretty stressful for them. And here's the gurgling. A lot easier to listen to and a lot better. And what we found was that the mothers who were stressed, who heard the cries, had babies who were much more stressed and distressed in the interaction following the cry or the stress stimulus compared to the infants who had the gurgles. So whatever the infants were responding to, they were aware that their mothers were stressed and they responded to that stress. So when you think about this mother that I just showed you, it's clear that she's really stressed by what the infant is doing. Of course, the infant's stressed by what she's doing. So you have this combination of stress going on between them that's disrupting their interaction with each other. But when we think about the methodological considerations, I know these are things that we often don't think about. You know, we talk about the mother being more irritable or whatever. There are lots of problems with these studies that have looked at methadone maintenance, have looked at opioid exposure. There are problems that really compromise and leave us with a whole set of unanswered questions, and they're really critical in terms of why you should care. So this is me as researcher. This is my true identity. There are a small number of subjects. Confounders are not analyzed. Comorbidities, depression, anxiety disorders are not analyzed. We don't know the dosage history. We don't know if there's polydrug use. Most mothers who are using these drugs use other drugs. A critical thing that often happens in studies like studies of opioid addiction is that there are matched controls. But the phenomenon is that if you have two groups of matched controls, low SES, poor education, single, minority status, and the one group you care about is the opioid withdrawal, what you have is two groups that have very high levels of risk factors affecting their behavior. So what you need is controls with low levels of risk. And then what we often find is that the opioid exposed and the matched controls don't really differ very much from each other, but they would differ from a low risk control group, where sometimes you get an ordering effect, that the opioid does have an effect, that those mothers do worse than their matched controls, and both of those groups still do worse than the low level exposure. We have problems with definitions. We don't examine the health status of infants. We don't have longitudinal studies. We don't have the timing of fetal exposure. We don't have often measures of what the meaning of the child is to the parent. Do they see the child as negative, as a problem, as difficult? And remember, there are three different groups, at least, of opioid, quote unquote, opioid using mothers. There are those who unfortunately are living on the street and taking street drugs. There are those, and this is most of our studies, are some kind of maintenance regime and are in treatment. And then there are mothers who are taking prescription medications, and they have very different patterns. But overall, in terms of my reading of what we know, the effects are small. And remember, they're group effects. They're not about individuals. The group of mothers who were on opioids compared to a group of mothers who were not, overall may have done a little worse. But it doesn't speak to every individual. And more critically, there's tremendous variability among individuals. It's very large. And we don't know what factors generate that variability. So let me close with this point rather than let me cut out some slides. So what do we do to intervene? One of the things I would suggest about is go back to what I've been talking about what a typical infant is. An infant is regulating the world, trying to get energy, and trying to make meaning about the world. So as a clinician, be like an infant. Try to make sense of the world. Infants are much better at it, by the way, than we are. They're amazing little beings. But you too can suspend judgment and try to make meaning out of the world that's in front of you, which is the two individuals, the mother and the infant. Ask yourself, what is their story? What meaning can I make out of this? Like the infant playing a game. Infants don't know what the game is until they play it. And we don't know what the story is until we hear it. And what is this dyad's unique way of being in the world for good or for evil? The infant who sucks on the mother's nose and has a game of doing that. There is no way you could predict that that's their game. And there's no way you can predict what's going to be going on between a compare what's good that's going on and what's poor that's going on. And the labels, because they're group labels, don't help. They won't help you know about this dyad. And indeed, I think very often they interfere because they bias you to see things in a particular way. So approach each dyad from a position of not knowing, with curiosity about the ways that this pair is doing in the world, and try to see them as individuals and try to see how the infant and the mother are making sense of the world and what are they doing with each other that is making sense for them about the world. So thank you.
Okay, everybody, if you want to either unmute or type your questions in, we had a couple comments already. They said, thank you for the information. The visual and auditory examples truly paint the real life picture. And just thank you for sharing your expertise. So hopefully get a couple questions here.
I can show a couple more things if you want.
Yeah, go ahead and show while people are thinking about a question.
Sure. Let me. So one thing that goes with being like an infant is Barry Brazelton's infantile approach to working with each parent-child dyad. Barry Brazelton was infantile only in that he could see things that we regular adults often don't see. So the first thing is to observe, describe, and share what you see with the parent. Do not interpret. So you could say something like, look at how she, meaning the baby, is doing X when I do Y, or when you do Y. So an example would be, look at how he's turning his head away when I shake the rattle. No interpretation, just describing it. See how he looks at you when you move backwards, when you moved away from him. No interpretation. Look, he spit up when you tickled him. It can be hard to hold back on the interpretation, but the observation allows you with the parent to begin to share what you're both seeing. And then you can come back to that thing and explore the meaning of it with the parent. And the generic response is, what do you think that means to her, to you? What do you think the spitting up means? What do you think it means when she looks away? Parents may have reasons for that. Oh, she doesn't like me, or she needs a break, or I think I did too much. So right away you have something from the parent which you can talk with the parent about in terms of what's going on. And you can say, yes, something like that. Yeah, she's upset. The tickling was maybe too much for her. It overloaded her, something like that.
We do have a question.
Let me just finish.
Okay.
I'll do. Yeah, it was too much for her. And then you can do, if some of those things are problematic, you can say, co-explore what to do. So if the parent feels like, well, she gets upset a lot and I'm doing this a lot, you can say, is it that there's something negative or problematic about the meaning that you and I both agree on, like spitting up is too much? And what can we do about it? Not what you can do about it, and not what I know to do about it, but what can we do with it? what can we do around too much tickling or too excited, or what sorts of things can we do to help that? Do you have any ideas? Do I have any ideas? And in that, you're collaborating and working in the same way that the infant is working with the parent during the interaction. You're taking the stance of the infant. Let me figure out what's going on here and how we can share the meaning together. So the question or comment?
Yes, we had one question here. Can you please speak to whether sleep training is an issue for dysregulating infants, if this can cause long-term problems for infants over time?
I don't think that sleeping issues, the dysregulated sleeping necessarily or tends to cause long-term problems. I think the long-term problems come out of how parents react to the sleep issue that the child may have. So they have one, and probably most of us have experienced this with our infants, or I see it with my daughter, and she has 4 children, so she considers herself kind of sleep expert, yet it occurs every time. Baby at 3 or 4 weeks of age, 5 weeks of age, wakes up, normal developmental change, had been sleeping better, gets up. Now what do? Well, every night a different thing happens. The naps change. If the parent gets really anxious about it, they begin to introduce a kind of inconsistency in what's going on. If the parent deals with it and this period of time of dysregulated sleep is dealt with, there's going to be another period of dysregulated sleep coming at around 4 or 5 months of age, when the infant starts becoming more alert and with more attention and reaching for the world. For the parent, that's a real challenge because the baby was sleeping better. Now the baby is sleeping more problematically. How is the parent going to react? And it's not just the parent's reaction now, it's their reaction. The infant is going to react to it as well. And it's not just around sleep, because what happens when there are sleep issues is that the parents and the infant change their routines and their interaction over the course of the day. So it becomes an ongoing issue. So it's not as if there were sleep issues early on, then there are no sleep issues, but those sleep issues early on lead to problems later on. I think much more likely is that you have an interactive process that gets put into place that may begin with a sleep issue, but soon begins to be infused because of what the parent is feeling and what the child is feeling, and the dysregulation that they feel during the day and over time, over that first year, that first 2 years of life.
Perfect, thank you. Well, and we're out of time. It's 1:15. So just a lot of thank yous, wonderful presentation. And we do appreciate your time today. And thank you for all this information. We are recording it, so we will be able to share it for Enduring CE for others to see if they couldn't make it today. So we really appreciate your time, and thank you so much for all the information you shared.
Thank you. Thank you for having me. I appreciate it a lot.
And thank you all for coming. Bye.